Our session today on palliative sedation. Our presenter today, Dr. Kevin Wade, is joining us, so we are very thrilled to have him. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Ottawa, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and original peoples in what we now know as Canada, and we are grateful to have the opportunity to present in this territory. Briefly, the Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada. Who care for patients, of course, with life-limiting illness and their families. We encourage you to check out our website, echopalliative.com, and a little link is also shared in the chat for you. The Palliative Care ECHO Project is supported by a financial contribution from Health Canada. Therefore, the views expressed herein do not necessarily represent the views of Health Canada. Briefly, many of you might know Pallium for our LEAP products. Predominantly one of our popular courses is our LEAP Core course. It is an interprofessional course that focuses on the essential competencies to provide palliative care approach, and it is accredited by the CFBC as well as the Royal College. We invite you to check out our website for more information on LEAP Core. Couple of welcome and reminders. So for comments and your introductions, and I do see that the chat is moving along, I'd like to welcome all of you. Thank you so much. We invite you to use the chat for introductions or comments. For any questions that you have, we'd like to let you know to please include them in the Q&A function. So do not put your questions in the chat. Please put them into the Q&A. And at the end of the presentation, I will moderate with Dr. Wade, of course, to answer all the questions that are going to populate throughout the session. Session is being recorded, so the recording and the slide deck will be emailed to registrants within the next week or so. And of course, please remember not to disclose any personal health information during the session. Regarding the disclosures, Pallium Canada is a non-for-profit organization funded by Health Canada. And we also generate funds to support operations and research and development from the Pallium pocketbook sales and the LEAP course registration fees. I myself do not have anything to disclose, and Dr. Wade's disclosure is right on the slide, as you can see. The whatever content you do see here, so it's been the complete independent control over the development, whoever is at this session presenting. So once again, my name is Diana Vince. I work at Pallium Canada as the Palliative Care ECHO Project Manager, and I will hand it over to Dr. Wade to introduce himself.
Hi, everyone, and thanks for joining us. It's really neat to see such a huge and diverse group of people signing in the chat. I can see people from here where I am in Victoria. I can see people from across the country, up in the Yukon, from Siksika territory in Alberta, and it's really neat to see such a good interdisciplinary group. I'm a palliative care physician here in Victoria, British Columbia. I work for BC Cancer and also for Island Health, and I cover call at Victoria Hospice. I'm also a clinical assistant professor at the University of British Columbia in the Department of Family Medicine, and still working for the military. I'm a major with One Canadian Field Hospital at Ottawa. I came from a background in the military, and that's what got me into starting to do medicine. And I'm also a MAID provider as well, and the topic that we'll be covering today is somewhat tangential to that. I'm happy to be here, and one of the things that I've brought from the military has been really a desire to work with a large interdisciplinary team, and it's neat for me to see sort of the diversity of the group that's signed in to be here for the presentation today, so thank you so much. What we'll be talking about today is the clinical considerations for palliative sedation, and we have three main topics I'm hoping to move through in some detail, but also relatively quickly to give us a lot of time for the Q&A at the end. The first is to identify the indications for palliative sedation therapy, and then to explain the differences between sedation and analgesia. So talking about how quiet patients aren't necessarily comfortable patients, and knowing that we need to still make sure that our patients are given appropriate pain control. We'll finish up by talking about pharmacotherapy for palliative sedation therapy and cover the various drugs that we use, not in any great detail with dosing and stuff, because that's stuff that's difficult to retain from our presentation, but just to compare and contrast and talk about the various medications and medication classes that are available. So first off, I wanted to talk about the indications for palliative sedation, which is one of the most important parts, is sort of recognizing what patients would benefit from palliative sedation versus those who simply aren't appropriate. As a palliative care physician, I work primarily in two settings. So I work at an outpatient pain and symptom management clinic, and I also work on an inpatient palliative care unit. And it's really on the inpatient palliative care unit where we're running into these questions about palliative sedation more often. One of the things that I do find is that we're often asked to do something like palliative sedation for patients who aren't appropriate, and in particular with respect to their prognosis. The typical prognosis that we want to have for a patient who's starting on palliative sedation would be a prognosis of less than 1 week, although after careful evaluation, we'll often extend that out up to 2 weeks. Really, the underlying purpose here in talking about that a patient should have is that the purpose of palliative sedation is to keep a patient comfortable until the natural end of their life. It's not intended to end the patient's life, which is one of the main differences between palliative sedation and medical assistance in dying. For a patient who has a prognosis of longer than 2 weeks, it is certainly possible that they could die from the dehydration and the inability to sustain themselves resulting from palliative sedation rather than from their disease itself with that longer prognosis. So just being careful to evaluate and understand whether the patient has an appropriate prognosis and will die from their disease within that period of time. The second consideration is that the patient has refractory symptoms, and the most common refractory symptom that results in palliative sedation is certainly confusion and delirium on the unit that I work and overall in British Columbia. That's what's acknowledged in our provincial symptom management guidelines. Less commonly than confusion or delirium, we see symptoms like pain, dyspnea, nausea, or even anxiety. Even less commonly than that, we'll sometimes talk about patients who have existential distress, which sort of often gets grouped in under the anxiety or some sort of an emotional component. And those patients may be eligible for palliative sedation after careful consideration and discussion with a palliative care team. Note that the symptom there is the delirium, or pardon me, the confusion. The underlying diagnosis may be something completely different, but we're focusing on the symptom that we're trying to manage. And the other consideration is that we have to determine whether that symptom is refractory. And refractory usually means not treatable by any mechanism that the patient is amenable to. So that certainly depends on what's available where you are. If you, for example, don't have the availability of a pump infusion, then it may be harder to manage a patient's pain. If you don't have epidurals available, then it may be harder to manage somebody's lower limb or even back pain. So it's very dependent on what it is that you have available in your setting to determine whether something's. And often that will require a trial of therapy. So we'll look at what we can offer on the next slide. The final thing is to say that we're in a setting capable of handling handling the monitoring and medication administration considerations for palliative sedation. So that means having sufficient staff available to be able to do the monitoring, that we're not just putting patients to sleep and sort of ignoring or forgetting about them. And also that we have the sufficient staff available and skills available for the medication administration component. What that means is that usually this is going to be on an inpatient or hospice setting. So I mentioned that I most commonly work in a palliative care unit where we run a lot of palliative sedation, and I would say on a weekly basis we have at least 1 or 2 patients who are undergoing palliative sedation at a time. There is possible palliative sedation at home, and certainly some of you may have more experience with that in different locations. Here in Victoria, we tend to be able to admit patients relatively, well, not easily, I would say, but we have enough capacity that these patients can come in unless they have an absolute desire to be at home. So I said that we would talk a little bit more about what are refractory symptoms, and there's a bit of a chicken and egg question here of whether the symptoms are refractory before you start attempting any treatment, or whether if you're required to attempt a treatment, before determining whether the symptoms are refractory. So you have to discuss this with the patient or their substitute decision maker and ask them what treatments they've attempted or undergone, and also what treatments they might be amenable to. If they are not interested in any further management, then that very much lowers the threshold of what is a refractory symptom. Most particularly, I see patients who have delirium and don't want any more blood work. Their most or medical order for scope of treatment here in British Columbia is an M1, which means they want no further laboratory investigations. And that makes it quite a bit more difficult for us to kind of work up and assess the possible management of delirium, because one of the first steps is to look for things like an infection or metabolic causes for delirium. And if they don't want that, then often that will route us towards palliative sedation much more quickly and easily. May also require consultation with a subject matter expert. In particular, if you do have palliative care consultation available, either anesthesia or another pain specialist available, or internal medicine when it comes to talking about things like delirium or dyspnea. Then finally, if the patient is amenable to it, then often we'll require a trial of therapy. So the most common time frame that we have here for a trial of therapy would be a 48-hour trial of therapy for something like typical antipsychotics, some pain medication, or even IV antibiotics if we think that a patient has delirium secondary to an infection, most commonly from a cancer at the end of life. It's often somewhat hard here to determine whether or not, again, another sort of chicken and egg question of whether or not you should talk to the consultant and see what is available, and then talk to the patient and see whether they want to talk to that consultant, or the other way around, whether you want to talk to the patient first and see what they would want to do, and then talk to the consultant if they'd even be interested. My usual first approach is to phone the consultant. From my perspective, it's better to sort of talk to them about what's available rather than talking to the patient, perhaps promising something that may not be available or may not be useful for them, like an epidural. Talk to your consultant, see what they're willing to offer, and then afterwards discuss with the patient to see whether they'd be amenable to that treatment that the consultant has to offer. In particular, that comes up with epidurals a lot on our unit. We're fortunate to have very good access to epidural analgesia from our anesthesia pain specialists in the hospital, but many patients aren't actually interested in that. They're not interested in something that keep them in bed, tie them to the hospital, and has potential harms, and may not even control their pain if they have more generalized pain. So we'll often sort of talk to the consultant first, see what they'd even be willing to offer, and then talk to the patient after that. As well, when we're discussing a trial of therapy for patients, one of the things that I mentioned here is about a trial of therapy with typical antipsychotics. So that's often for delirium, where we'd be doing a trial with Nozinan or Haldol or another typical antipsychotic, trying to manage their confusion. And there's sort of this blurry line between what exactly is a trial of therapy now if we're giving typical antipsychotics, which are some of the same medications that we're going to then turn around and use for palliative sedation. And the general consensus is that this is about the intent of the therapy, that during this trial of therapy, what we're trying to do here is manage their confusion, see if that confusion can get better, even maybe co-administering it with some IV antibiotics to try and treat an infection, versus that the sedation that comes from those typical antipsychotics is not intentional. If we could manage their confusion without them being sedated, that would be a happy circumstance. It's usually not possible, but we try to do that. On the other hand, with palliative sedation, this is not consequential sedation. We're not giving typical antipsychotics to manage confusion. We're giving typical antipsychotics specifically because they're sedating. So we want those patients to be sleepy. We want them to have their symptoms managed because they're more sleepy. And so that's really intentional sedation versus a trial of therapy, which was sort of consequential or unintentional sedation. Moving on, I think one of the most important concepts to get across is the idea of separating out sedation and analgesia. And I talk with the residents that I work with quite frequently. And that quiet does not equal comfortable. I think actually she's in the audience, but Elizabeth Antifo is a clinical nurse specialist in interior health who did this presentation with me back in March. And she has this very sort of stern warning that says that quiet does not equal comfortable. And I agree with that. And I emphasize that to the residents all the time, because it's an easy mistake to make, that someone who is asleep and not making a ton of noise, not complaining, maybe, we can mistake them for being comfortable, but that's not entirely true. We know from research in the ICU setting that somebody can be very much look peaceful and look asleep, and then when they wake up and they recover in the ICU setting, they tell us that they were in a significant amount of distress and a significant amount of pain. So we want to measure these two things independently, and for sedation, we most commonly use the RASS-PAL scale. RASS stands for Richmond Agitation Sedation Scale, and the PAL is just a different way of measuring that because this is a scale that was developed in the ICU, and they use a painful stimulus to see whether the patient is responsive. In palliative care, we don't want to use a painful stimulus, and I'll go through the RASS-PAL in a subsequent slide. One important thing to emphasize here is that the Pissarro scale is not appropriate. That's a scale to measure someone's opioid sedation from opioids, and is not one that's validated in the setting to manage to determine whether someone is appropriately sedated or not. And even in the sedated patient, we want to continue to manage their symptoms as well as possible. So managing, for someone who had pain, we can't sort of stop their analgesics just because they're now asleep. So analgesia is the control of pain, and sedation is the control of their level of consciousness. This is the Richmond Agitation Sedation Scale, the palliative version, as I mentioned. So it's slightly different. Some of you may work in an ICU setting or have worked in an ICU setting. And certainly with this, in the ICU setting, to test whether someone is not rousable, they would use a painful stimulus like a trapezius squeeze or a sternal rub. In the palliative setting, we don't want to use that. So that's the main difference. What we're looking for here, and most commonly with palliative sedation, is we're aiming for a sedation level of -3. I mean, you sort of look at this and you say, well, why don't we aim for a sedation level of 0? And that would be wonderful if a sedation level of 0 were possible. But the idea here is that we've tried with this various trials of therapy that we've tried to do something to get them to a sedation level of 0, and they haven't been comfortable at that point. And so that's why we're aiming for a more moderate sedation, or sometimes even trending towards a deeper sedation like -4 or -5. As I mentioned, we still want to separate out the management of sedation from the management of pain or analgesia. And so we still want to have a separate scale to look whether or not the patient is in pain. So this is a non-responsive patient. There are several validated scales that you can use to see whether a patient is in pain despite being sedated, that are initially developed for patients with severe dementia who are nonverbal and unable to demonstrate whether they're in pain. There are other scales that were developed in an ICU setting. One of the ones that you may have heard of is the Critical Care Pain Observation Tool, also known as the CPOT. But the most common one comes from the dementia literature, and that's Pain AD, or the Pain Assessment in Advanced Dementia Scale, which again is for nonverbal patients with dementia. And it's a 10-point scale where anything above a level of a 4 or greater indicates that the patient is in moderate pain and may require increased analgesia. Less than 4 indicates that they may just require comforting or non-pharmacologic approaches. And it's a combination of breathing, negative vocalizations, so sort of calling out or moaning, facial expressions and whether they're grimacing, body language, and in particular, this clenching or basically pulling their limbs into their center, and consolability, their ability to be consoled or comforted by good and appropriate nursing or healthcare. Now we move on into the third thing that I wanted to cover today, which is the pharmacology. And I've deliberately left the doses for these various medications off because, again, I find that's something that is, when we put it on here, it's not easy information to retain. I mostly wanted to talk about the various medications and the various classes of medications that are available. So by far across the country, the most common medications that are going to be used for palliative sedation are neuroleptics or typical antipsychotics. And the two most common of those, at least here in British Columbia, are methotrexate, the brand name Nosinand, or haloperidol with the brand name Haldol. One important thing to note is that Haldol is often insufficiently sedating. So we see that a lot in the psychiatry setting. I mean, anybody that's worked in psychiatry has probably had the experience of getting patients with agitated delirium and perhaps giving them 5 in 1, so 5 milligrams of haloperidol at a time or 10 milligrams of haloperidol at a time. Those doses are seen as insufficiently sedating because Haldol is what's considered a high potency neuroleptic, meaning it has more, more affinity for the dopamine receptor and less affinity for other receptors like the antihistaminergic and anticholinergic effects that achieve sedation. So a low potency, even though it's sort of contradictory in terms of what we say, the low potency neuroleptic like methyltrimeprazine or Nozanan is quite a bit more sedating because it has a greater antihistaminergic and anticholinergic effect than the others. And the other benefit that we get with methyltrimeprazine is it does have indications that it has some analgesic effect as well. So for a patient with pain, there's literature in the United Kingdom that suggests that Nozanan actually has some analgesic effect. And so that's one of the reasons we prefer it out here for palliative care. The other drug that you'll sometimes come across is loxapine. I know we were using that a few months ago here in British Columbia because we actually didn't have Nozanan available. It was on back order. And I'm not sure if that was everybody's experience across the country, but at that point we used loxapine, which is another low potency, typical antipsychotic like methyltrimeprazine. Moving on, there's benzodiazepines. So midazolam is probably the preferred agent for palliative sedation, but it's limited because it has to be used in a setting with fairly intensive management available. It's a short-acting and highly potent benzodiazepine, but because it's short-acting, it has to be given as either a constant infusion or Q1H dosing, or sometimes even Q30 minutes. So that gets, without the availability of a CAD pump or some other sort of syringe driver or infuser available, it's very difficult to run a midazolam infusion in another setting. So that makes it less commonly used. The benefit of it, though, is that because it is so short-acting, patients can give themselves an extra bolus dose, or a family member can give them an extra bolus dose, pardon me, if they do notice the patient noting symptoms, or a clinician bolus, which takes effect very quickly within a matter of minutes. And it's rapidly titratable, so we can adjust that infusion rate very quickly and get the infusion rate up to an appropriate one. With midazolam, we'll almost always be able to achieve sedation in patients, except in patients with a really high benzodiazepine tolerance. So those with a history, for example, of alcohol use disorder, or a history of high benzodiazepine use for seizure management. Lorazepam is on the list here, mainly because lorazepam is probably the preferred agent in the home setting. Now, as I mentioned, it's not something that we have a lot of experience here in Victoria. If somebody has more experience with that, I'd appreciate your comments, certainly in the Q&A. But it's available as a sublingual medication or a buccal administration, and it's probably the one that could most comfortably be given to a patient at home without actually needing subcutaneous access like you'd need for the rest of these medications. It's longer acting and less rapid acting than midazolam, so it's less titratable and less potent, so it will require a higher dose of medication to achieve the same effect. The other less commonly used medications are barbiturates. So for example, phenobarbital, which we use here in Victoria for those patients. Often, most commonly we're using it for patients who have been on a midazolam CAD and then not managed to achieve sedation at the maximum dose of midazolam that we can run, which is 10 milligrams per hour. That's commonly patients, again, with a high dose of benzodiazepine used for seizure management, or patients with a history of alcohol use disorder, and they'll respond well to phenobarbital being added on top of the midazolam. The other medications that, again, we use fairly infrequently here, but some of you may have more experience with, is surgical anesthetics like propofol, or like dexmedetomidine, or Precedex, as it's known, which is sort of infrequently used for patients most commonly who want palliative sedation with some level of responsiveness. It gives a somewhat lighter sedation. So for patients who still want to be able to sort of interact with their families, but have had refractory agitation, dexmedetomidine can be a very useful drug for those patients. So the next section that I'm going to talk about here is the nursing considerations for palliative sedation. I see that we have a lot of nurses, registered nurses and clinical nurse specialists in the audience. I won't claim any expertise in this. These slides were actually developed by Elizabeth Antifo, again, who was a clinical nurse specialist in interior health, who worked with me before I made the move to Victoria so that I'd be closer to family for my young kids. But this is a nod to Elizabeth, who developed these slides and has a lot of expertise on the nursing side. So what we're going to assess for with the nurses, for nurses who are monitoring a patient on palliative sedation, is we're going to monitor the level of sedation. We're going to look at their level of pain, the level of dyspnea, And then we'll integrate all of those into some sort of decision or recommendation, which will often be nursing driven. As a physician ordering palliative sedation, I'll usually have one CAD, or two medications, one of them for sedation and one of them for analgesia and dyspnea. And typically I'll provide parameters or ranges, but it's really a nursing level decision to determine what the next step is, whether the patient is in pain or whether they're insufficiently sedated. And there are recommended tools for each of these. I have already mentioned the RASS-PAL scale and the pain AD scale. And then there's also, we'll go through what's called the RDOS scale, which is the Respiratory Distress Observation Scale, one for dyspnea. And then almost every site that has palliative sedation will have some sort of a monitoring record for palliative sedation with the assessment tools, whether it's built into your EMR or whether you're still recording it on paper. Level of sedation, as I pointed out, we've most commonly, and I've never really encountered anyone using a scale other than the RASS-PAL scale. I mentioned the Pacero scale, which I think is, we don't use it much out here in British Columbia, but I think it's a common Ontario scale to measure opioid sedation. This is a 10-point scale, and we're aiming for about a -3 or moderate sedation when the patient is settled and then when they're appropriate. Often what I find is that we will start off aiming for -3 and going through those assessments frequently and seeing whether the patient can open their eyes and then close again. If they can't be settled at that level, then we're aiming for an even lower sedation, like -4 or -5, and make the patient non-rousable. Level of pain, I've already been through the pain AD scale, but that pain AD scale needs to be done especially frequently when the patient is first being sedated in order to determine that their analgesia is still adequate, because they won't be able to give you those standard indicators. They won't be able to say, I'm in pain, or it hurts. Even if they have delirium, often a patient who is verbal can still verbalize in that moment that they remain in pain. Once they are sedated, they may still be in pain, and you have to continue using that pain assessment scale to determine whether they need that. So those patients who are quiet require increased monitoring, not decreased monitoring. I mentioned that there is another validated scale for a patient who's undergoing palliative sedation for dyspnea, which I will say is fairly uncommon for me here in Victoria. I would say it's probably 2 or 3 times a year that we'll have patients who have dyspnea that is so bad that they'll require palliative sedation for that. Some of you may have more experience with that than me, but this respiratory distress observation scale, again, is a validated scale which uses clinical measures. So it does actually require monitoring the patient with heart rate and respiratory rate alongside nursing observations to determine whether or not that patient is short of breath and needs improvement in their level of respiratory distress, which can come from a variety of factors. I mean, it can be as simple as adding air in the room, blowing air around the room. It can come from opioids, or it can come from oxygen by nasal prongs or a mask. And that's a determination that often will be made by nursing and physicians in close discussion. So just to summarize, that quiet does not equal comfort, as Elizabeth says, and that clinical decision-making and problem-solving remains extremely important for patients after they're sedated. You have to keep using your pain AD and your RDOS tools even after the patient is sedated, and basically monitor that, especially when the palliative sedation first starts. Very frequently, when you're first starting this, you'll start in our case, most commonly midazolam CAD, and then reassess their pain and their respiratory distress about 3 to 5 minutes later. And then if things go well, if they continue to have low levels of pain and low levels of respiratory distress, then you can become more and more infrequent in terms of your monitoring after that sedation starts. So thank you very much. That's fairly rapid fire for the things that I wanted to cover today. And now we used to have a case study here, but we've removed that case study, I think, in favor of a Q&A.
Yes.
And at this Q&A, we'll have a chance to answer questions. So I'm
Fantastic.
looking forward to everyone's questions.
Great. Thank you so much, Dr. Wade. What I'll do is I'll go over the questions and then you can answer them. So the first one we have from Melanie Doucet is, I have seen the option of long-term care epidural. How long is long-term? We do not use this option much here. So
the longest epidural we've run in Victoria was about 2.5 months which is certainly much longer than most of the anesthesiologists are comfortable with. I mentioned that we're quite lucky to have a good working relationship with them here. And we had a patient who had a vulvar cancer and also peripheral vascular disease with severe leg pain, who improved just so much on an epidural. She was on really high dose opioids. And when the epidural started, we were able to wean those opioids off, and she actually ended up living another 2.5 months. So that wouldn't have been a patient who would have been appropriate for palliative sedation, really, with that longer prognosis. The epidural worked extremely well. And I think, in some ways, I think everyone is sort of like, okay, how long can we run an epidural for? But in the end, we ran it for 2.5 months, and it continued to work extremely well for that time.
Okay. And right underneath that one, it says, do you have any advice for paramedics in community how to manage acute delirium? Is there any program for after hours consultation with palliative care team to help develop treatment plan?
Yeah. So here in British Columbia, I haven't done a lot of work with the paramedics, but I do know that they have a set of palliative protocols that they can use. And for advanced care paramedics in British Columbia, I think that their medication of choice is ketamine to help manage delirium, which we don't use a lot for delirium in palliative care in hospital, but we also have, I guess, a lot of support, more support than you would have. And I think the point of the ketamine is that it works quickly. It's relatively benign for most patients once they recover from the ketamine, and it's something that you can give to a relatively undifferentiated patient. We also have a race line. So I'll confess, I've never heard of a paramedic calling the race line, but I don't see that they couldn't. They would probably have to go through an an emergency physician on call service. My understanding is that they would go through EPOS first, and then the EPOS physician would have to get palliative consultation. That's a work in progress. There was a really extensive project here in about 2018, 2019 for paramedics to be doing more and more palliative care, which I think is absolutely excellent, trying to handle patients at home and not necessarily bring them to the emergency department. A lot of that work got interrupted by COVID, and we're just trying to pick it up now and try to see what else we can do to help paramedics with palliative patients, because I know that paramedics don't want to be bringing those patients to an emergency department. The patients don't necessarily want to go to an emergency department. They just want to feel better. And I think we could do a lot more. So it's a very good question, but we do have a few tools here, but not extensive ones.
Okay. All right. The next question is, what is your maximum dosing for midazolam rate and why?
Yeah. So for us here, it's 10 milligrams per hour, and that's because we try to limit our infusion rates to 2 milliliters per hour. And the concentration of midazolam that we have available is 5 milligrams per milliliter. So I guess theoretically you could go higher. As an IV, I've seen it maxed out at 30 milligrams per hour. That was for a patient with management of delirium tremens, actually, that I was monitoring. And that you can obviously run at any rate you want, but if it's not working at 30 milligrams per hour, then you probably need to add another agent like Prexadex or dexmedetomidine. But for us, it's 10 milligrams per hour. I see the follow-up question, you could use multiple CADs to run higher rates, and absolutely we could. I think that it's very rare that we, if we are up to 10 milligrams per hour, that we would just continue titrating the midazolam and hope that it works. At that point, we would probably add phenobarbital if we weren't getting the response that we wanted at 10 milligrams per hour, or dexmedetomidine.
Okay.
Yeah, but that's true. We could run multiple CADs.
Yeah. Okay. Regarding lorazepam, it works only if the patient has enough saliva. Is the mouth too dry? It won't dissolve. So I think this
okay. Yeah.
Comment.
I mentioned I have fairly limited experience with running buccal lorazepam, but that's a good point. I suppose, if you had it as a liquid, or if you had, if you could spray and dissolve it. But yeah, I mean, it's well absorbed buccally. It's just, you got to actually have liquid to get it through the mucosa.
Yeah.
That's a good point. I've never thought of that.
Yeah. Our next question, can you please explain regarding a continuous palliative sedation consent? Also need a consent when sedation is administered at end of life?
Yeah. So palliative sedation is a medical procedure. It's a medical procedure that requires consent from the patient like any other medical procedure. And I think that means that the patient has to be informed of the possible alternatives, of the, what other things could be done in order to manage it. And then also of the consequences of palliative sedation, namely, and I'm usually quite blunt about that you'll sleep. The intent of this is to put you to sleep, to keep you to sleep until the natural end of your life. I don't, and I make it quite clear that I'm not planning to end their life with the palliative sedation. That's what medical assistance in dying is about. That it is a medical procedure and we treat it as such. So just like administering anything else. Depending on your institution, some places will require like an actual written consent from the patient or substitute decision maker for palliative sedation. We don't here in Victoria, and none of the settings that I've worked in have actually had like a written formal patient consent for palliative sedation. I believe, somebody can correct me if I'm wrong, but I believe in Quebec as well, there's sort of like a monitoring requirement that came under the soins de fin de vie law, where for palliative sedation patient, you actually have to get explicit consent and also report it to the government, which again, we don't have a requirement for that here in British Columbia.
Okay. The next one is PainAd gives points for what would often be normal end-of-life respiratory patterns, such as Cheyne-Stokes. How do you deal with this when using the scale?
Those points, if everything else is going well, those points shouldn't matter. They shouldn't be enough to push the patient up into an area where you're actually giving more analgesics. So if somebody has like labored breathing or Cheyne-Stokes respirations, that only is enough to give them a 2 on the scale. And so it seems reasonable to me that you should like beware that and not just assume that that's Cheyne-Stokes respiration. And so, if it's just that, then maybe that allows you, the point is, I think, to go through the assessment and see whether that's just Cheyne-Stokes breathing in isolation or whether it's possibly an indicator of pain otherwise.
Okay, perfect. Can you comment on typical sedation for chronic vent clients in LTC choosing to discontinue vent BiPAP when continuous infusion is not an option?
Not with any degree of expertise or authority. I would usually use a midazolam infusion. We do see vented patients or BiPAP patients who are discontinuing that in hospital, but we'll use midazolam almost exclusively for that. And in this question, they're presupposing that we don't have midazolam available. Boy, that's a tricky setting to be discontinuing a vent in. I'd have to say that just very continuously administered midazolam is probably still the best option. So I would start a subcut or IV line, and I would have someone there at the bedside giving aliquot to midazolam, getting the patient sedated before. I mean, you will see this happen with like a patient who's sort of airvo dependent or BiPAP dependent, and turning that off. But that's a very good question. I think I would just have to run the midaz almost as if you're running an infusion yourself. Because presumably the expectation is that patient is going to die from discontinuing the vent. I guess the assumption there is you're not going to be there for that long. So it's going to be pretty intensive management and you're going to want to be very conscientious and give a decent dose of medication. But continuing that,
Okay.
Good question. I don't have a lot of authority, but I would say we would run a midazolam CAD. And so my answer, if you can't run a continuous infusion, is to just, you run something frequently enough that it's almost like an infusion, like a Q20-minute PRN dose or something.
Okay. All right. The next one from Carol Northcott. I have been reading about the use of lorazepam in palliative care setting, concerns regarding paradoxical effect and should be avoided. You have any thoughts?
Yeah, it's probably true. We don't use a lot of lorazepam except in patients who are already taking it here in Victoria. So we'll see a lot of patients who have been prescribed lorazepam, for example, previously for anxiety, or lorazepam PRN for seizures. And we'll continue it in those patients, but I do agree, like it's not my preferred choice for management in hospital. For someone who's looking for that sort of light sedation, agitation management, I much prefer haloperidol for that. So, and exactly that. We here in Victoria, again, we sort of there's a geriatrics team and there's a palliative care team, and we do have some overlap, but we don't see a ton of patients with dementia on the palliative care unit. So I think that would be a setting where you'd even be more concerned about it because of that paradoxical effect of lorazepam in dementia most commonly. But I agree, I don't find it an excellent drug, and it often doesn't do what we want it to do.
Okay. The next question, can you comment about using midazolam continuous infusions for light sedation, i.e. RASS goal 0 to -1?
We'll do this rarely, especially if we sort of are thinking that a patient might need palliative sedation in the future, and we want to get, I guess, like once you have the CAD set up and everything's ordered and you have the medication, then it's very easy to turn up the rate in the future if you think you need it. So sometimes we'll do this, very rarely at a super low rate, like 0.5 or 1 milligram per hour. And sometimes we'll even just do it overnight, almost like the patient has insomnia or their nights are extremely difficult, and we'll ask for it to start at, say, 8 p.m. And run until 8 a.m. the next morning. And then the nice thing with the midaz is you can turn it off and it goes away really quickly. It's not like, if you give somebody a sleeping medication like Zopiclone, or if you give somebody an atypical antipsychotic like olanzapine, that doesn't go away all at once. It goes away very slowly over the course of the morning, and often their morning is sort of like, loopy, and they're higher risk of falls and stuff. The nice thing with midaz is getting rid of it. I wouldn't say, if you're actually thinking that deliberately you want to have this patient at a RASPAL of 0 or -1 for like a prolonged period, then dexmedetomidine is probably the preferred medication in that setting. I mean, it's limited by expense and clinician experience, but midaz, they're going to get used to it if you use it for a prolonged time, and then it's not going to work anymore.
Okay. The next one, it is a comment. It says, a challenge in my setting is that this is a rare occurrence. The nursing staff, which administer and monitor this, rarely have previous sedation experience in other settings. It is difficult to describe the difference between sedating and the natural changes of the body in the last days and hours of life. And then she added that there is hesitancy related to over-sedating and a hastening natural death.
Yeah, absolutely. I mean, and doing it infrequently is way harder than doing it frequently. I mean, you just sort of get used to it and run it frequently. I would say the biggest things to do something infrequently, it emphasizes the importance of having, written protocols, like a written monitoring parameter, or, I find actually on paper is best rather than in the EMR. Like the EMR is great, but we just use PowerChart out here, and we just get buried in information from that. And having it on paper maybe emphasizes the importance of monitoring palliative sedation. So some sort of a monitoring record to kind of emphasize the use of what you're doing with clear, parameters or guidelines from the physician to say, here's when you should turn up the sedation, here's when you should turn up the analgesia. And similarly, on the physician side, having a good pre-printed order that follows your provincial guidelines. We just redid the provincial guidelines for palliative sedation out here in British Columbia. They should be coming out in the next few weeks. And really like having a PPO that sort of, can go through, the clinician can go through, especially if they're only doing it once or twice a year, and kind of check off boxes where, often it will say, this is the recommended drug, this is the recommended dose. And that checkbox approach is really valuable. I mean, it's the same as like pilots doing an engine failure drill, right? They don't just try and memorize it and be like, oh yeah, I learned this back in training. They have checkboxes to go through and do the right thing, and so they don't forget about something. But I agree, it's difficult to do something infrequently. I mean, in regards to over sedating and hastening natural death, I suppose I can understand that being a concern. I mean, certainly, there is always that possibility that that they're not dying from their disease, that they're dying from the sedation. I think that's why it's so important to identify the patients who are dying from their, and do have an imminent natural death from their disease within 1 to 2 weeks. And then, at the very least, you can say, well, this is someone who is dying from their disease, and the sedation is merely an attempt to palliate that. But people die. I mean, it's not unique to palliative sedation. People die from the consequences of palliative chemotherapy all the time, and we don't, people get infections and die from febrile neutropenia or sepsis, and we don't sort of say, oh, well, that, they never should have, I mean, I guess in retrospect, you can say they never should have done that palliative chemotherapy, but going forward, do palliative chemotherapy because it helps more patients than it hurts still.
Okay, yeah.
So I'll sort of, make that equivalence between palliative sedation, that there are some patients who may be dying slightly sooner than if they weren't on palliative sedation, but we kind of got to push through and still help as many people as we can.
Okay. And how do you deal with clients who are already on benzos? We have had trouble getting people sedated when they are already on benzos.
Yeah, I mentioned that with the MDAS, that we sort of, the most common situations we'll run out of room are either people who are on chronic benzos for seizure disorder, like a big dose of clobazam or something, or patients with alcohol use disorder. Or, I mean, sometimes people just get there for anxiety, especially if they have anxiety associated with like a cancer or something. They'll just get, more and more lorazepam and start taking 8 lorazepam a day or something, and they're on these high dose benzos. The common thing that we'll use for that is either a neuroleptic, so the Nozanan most commonly, or switching to phenobarbital, which will work in patients who are benzo dependent.
Okay. And this one is a comment from Joanne Davidson. We used injectable Ativan on the palliative response team subcutaneously in Victoria. And somebody else did answer that they use that as well. Just find that it burns is one of the comments that we received.
Yeah. That's Josie saying that. Thanks, Josie. Yeah, so they have it available. I don't commonly use it on the inpatient side, but it's something that can be used to help with sedation, especially for someone who's not getting a good response to Nozanan.
Okay. The next one is in my center. What we do for buccogingival lorazepam on dry mouth is just to put 1 to 2 milliliters of water in the vestibule before administering the medication, of diluting it with a little bit of water. So this is another observation.
Yeah.
Now, a question we have: can you speak to the fear of palliative sedation hastening death?
Yeah, I guess that I sort of briefly addressed it in that last question, talking about sort of nursing hesitancy with the worry about mixing up end of life symptoms with symptoms needing palliative sedation. And the idea here is that we can't avoid that possibility. With any medication that we're giving, there is a possibility that it makes the patient worse rather than better. That goes for everything. I work at a cancer agency, and the most common example that I see is palliative chemotherapy, where someone is sort of doing well, but they have progressive disease, and then they start a new line of treatment, and those, sort of often 3rd or 4th line treatments with palliative chemotherapy don't go well, and they hasten the patient's death. Absolutely, they die sooner than they would have if they never did that. I think the message there is that it is still sort of the intent that matters, that our intent is to keep them comfortable. And if that has the sort of side effect of hastening the patient's death in some patients, that's an inevitable consequence of giving medical care to people. I mean, that's, we couldn't do surgery or literally almost anything in medicine if we didn't accept that some people are going to be harmed by the things that we do. It's just that we're helping more than we're harming.
Okay. And
yeah,
do you prefer...
I feel like that's a bit of an inadequate answer, and I'm sorry to the questioner.
No.
I wish I had a better statement, but to put me on the spot, I just still think we have to do the most good for the most people, and trying to do as best for the patient that's in front of us, with the hope that they don't die sooner from that, but that they are comfortable at least.
Okay. The next question: do you prefer to do a larger loading doses of medication to start sedation and draw back, or start lower and see what is needed?
It's dependent on the situation. I'll usually just start lower and see what is needed, like titrate up on a midazolam infusion. The situations where I'll start with a big dose and then drop back is usually if there's sort of some unmanageable situation going on. So the classic example of that for me is a patient who's in restraints. One of my very firm lines is that nobody should die in restraints. And if a patient is in restraints due to agitation or aggression or violence, that's when I'll, or even without restraints, but just they're aggressive or violent, that's when I'll give a big loading dose, get them asleep, and then we can back off afterwards. Otherwise, I'll just titrate up slowly.
Okay, all right. And how do you manage with unwanted side effects such as bowel, bladder, and incontinence from hourly dosing with sedatives?
So the bowel and bladder, I mean, I'll admit a lot of the patients that we're seeing are incontinent anyways before they start the sedatives.
Mm-hmm.
Yeah, so it's often not something that we're sort of considering because they were already incontinent, whether it's from being PPS 30% and bedbound already from pain or lack of energy, or because they're delirious and not able to recognize when they need to go to the bathroom. For the bladder incontinence, we'll always put a Foley catheter PRN order if the patient is okay with the Foley, or they can be incontinent in briefs. Again, for bowel incontinence, they're not going to be eating anything. They're still often going to be putting out sort of infrequent bowel movements, but we'll just do personal care and change them.
Okay.
That's sort of one of the consequences of the sedation.
Okay. We have 4 more questions, and I'll try to go through them before we finish. If someone has been on subcut infusions to prevent dehydration, do you always discontinue it when starting palliative sedation?
That specific question has never come up for me. Yeah, we don't run a lot of, like, hypodermoclysis is the subcutaneous, usually just normal saline at like 50 to 75 milliliters an hour. We just don't do a lot of it here in Victoria, to be honest. So I don't have a good answer for that from my own experience. Just thinking, I mean, if they were on that to prevent dehydration, I think a lot of it would be situational. So is that because they're on that as an attempt to bridge to something else? Or is it that they are trying to just survive longer from the, so that a family could get there or something like that, in which case it's a bit strange to be starting palliative sedation if family's going to get there and they're just going to be completely asleep anyways. I'm trying to just sort that out in my head right on the spot here. I think it would be situational. I think my bias would be to stop that before starting palliative sedation, unless I had a really good reason to continue the subcutaneous infusion, like the hypodermoclysis. Mm-hmm. I would usually, by and large, stop that, but we really don't run a ton of that here in Victoria.
Okay.
Yep.
And if hastening death is not the point, but pain relief, hastened death is an unintended double effect. Is it considered an ethical approach to end of life?
Yeah, this is a statement, not a question, and I agree. I think that double effect means that we can have patients sedated. The goal is to manage their symptoms, and they're dying from their disease, and ultimately, we just have to be willing to take that risk that they may die. There is a possibility that they die sooner with the palliative sedation. And that's unfortunate, but there's no way of getting around that risk and still helping the patient.
Yeah. And what has been your experience with the use of Precedex for sedation for delirium? Have patients been able to have communication with family, or does the delirium remain a problem and need deeper sedation?
Usually the second. We've had a few where the patients have sort of stabilized for a few days, and then it always seems to come back, and then we need to do deeper sedation. I can't say, I mean, I read literature around Precedex, and everything seems amazing about it, and it seems absolutely wonderful, and it makes me question whether I'm doing something wrong, because it hasn't been my clinical experience so far the Precedex has not actually been as useful as I kind of want it to be. So yeah, I would say more the second. Usually the delirium remains a problem. They kind of calm down and they're less agitated, and often if the family is there 24/7, they'll be able to sort of interact with family, and that can be quite useful. But I would say most commonly within about 24 to 48 hours after doing that, their delirium worsens again.
Okay.
Yeah.
And what are your thoughts on the use of palliative sedation for existential suffering?
Yeah, I mean, this is also informed by my experience as a MAID provider as well. Now, I'll say that most patients I mean, Victoria is a sort of a high medical assistance in dying area. And so I would say most patients with existential suffering are requesting MAID rather than requesting palliative sedation. Often that existential distress predates the 2 weeks before the end of their life. And so if that is such a refractory and unmanageable symptom for them, then they don't necessarily have palliative sedation available for them, because I'm not going to break that sort of 1 to 2 week prognosis rule for someone who is just because someone is distressed. People can have MAID 6 months before they die, but they can't have palliative sedation 6 months before they're going to die. I think it's ethical under certain circumstances. I certainly, I would, if a patient met all of the other criteria and circumstances, but they said, well, I don't have pain, I just don't want MAID. That's a rare patient, but I would certainly be willing to do it for existential suffering in the right patient at end of life. It's just that so few people meet that criteria. Like for someone to have be otherwise, have no refractory symptoms, be otherwise extremely upset about being alive and have existential distress, and also not want medical assistance in dying, and also be that close to the end of their life. That's a lot of criteria to meet. So I think just clinically, it's going to be rare, especially in an environment where medical assistance in dying is legal, and not just legal for me here, but also like widely accepted by the patient population. That's sort of just a very common thing a lot of patients have experienced in family members and stuff. So that's the challenge. Is not because I have ethical sort of qualms about palliative sedation for existential distress. It's that I just don't get asked that often.
Okay. Well, thank you so much, Dr. Wade, for taking the time to answer all those fantastic questions and for such an in-depth presentation today. We'd like to ask the participants to please fill out the feedback survey that you will find a link in the chat. And of course, as mentioned before, a recording of the session will be emailed to registrants within the next week or so. We'd like to thank our presenter today, and we'd like to thank everybody for your participation. Stay tuned, and thank you so much for joining us today.
Yeah, thank you so much. It's always a privilege to be able to present to such a big group. I really appreciate it. Excellent.
Thank you.
And for me, I just, to be a part of such a diverse and interesting team and people asking questions all across the country, it's just a really fantastic feeling to be able to present to a group like this. So thank you all.
Thank you so much. We're thrilled to have had you. Thanks, everyone.